The following program does not offer personal medical advice. Please consult your doctor before using any treatment or product we cover. Welcome to Go to Health Media with your host, Jonathan Marks. We provide a welcoming environment where experts educate you on important health topics, answer your questions, and provide information from which you can benefit in consultation with your doctor. You can visit and subscribe to the show at gotohealthmedia.com. And now, here is Jonathan Marks. Hey everyone, this is Jonathan Marks. Welcome back to another show. Today we're talking about ADHD. It's Attention Deficit and Hyperactive Disorder. It's the same as ADD, which is an older term. But based on research in the 1980s and since, we now know that ADHD occurs equally in both males and females. It becomes apparent by the early teenage years, and it is a lifelong disorder. It can affect 5 to 8% of the population. That's 15 million people in the United States. So it's important that we understand what ADHD is and how it can be treated. So we're going to discuss a number of topics today. Let me just list them quickly. Understanding ADHD, the impact on daily life, co-occurring conditions, diagnosis and assessment, treatment options, and research and future directions. So put on your seatbelt and stay with us. We're going to be really getting into the depth of what ADHD is. We'll be back to our show after this quick break. This interview is a fantastic overview of the latest evidence on what we know about ADHD from one of the foremost experts in the world, Stephen V. Faraone, PhD. Because there is so much valuable information in this interview, we are offering a PDF transcript of our conversation so that you can review, retain, and share the information in this interview. We are making this transcript available for only $1.99. Download your copy today so that you can refer to and share this valuable information about ADHD. As a bonus, you will also receive a copy of the World Federation of ADHD International Consensus Statement, featuring 208 evidence-based conclusions about ADHD and compiled by almost 80 experts worldwide. Download your transcript and bonus at bit.ly/ADHD evidence. With us today is Stephen Faraone, PhD. He's Distinguished Professor of Psychiatry and Behavioral Sciences. He's a Professor of Neuroscience and Physiology. He's also Professor of Neuroscience Graduate Program, all at SUNY Upstate Medical University. He's the Principal at the Institute for Human Performance, and he is the President of the World Federation of ADHD, whose board members represent the United States, the Netherlands, Germany, Australia, and the People's Republic of China. He's also principal at the ADHD Evidence Project. And if you want to learn more about that, it's adhdevidence.org, adhdevidence.org. Dr. Faraone has authored over 700 journal articles, editorials, chapters, and books. And in 2005, the International Statistical Institute determined him to be the second highest cited author in the area of ADHD. So welcome to the show, Dr. Faraone. How are you today?
I'm doing great, Jonathan. Thanks for having me.
Good. And I just want to let everybody know that Dr. Faraone and I worked together for 10 years on a wonderful project called ADHD in Adults. It still exists on the web. It's ADHDinadults.com. We trained 33,000 health professionals about how to recognize ADHD and treat ADHD. And we also have over 900,000 views on YouTube. So I highly recommend you go to that site. So great to be back with you, Steve. It's wonderful to be talking about ADHD again and educating the public. So let me ask a few questions, a number of questions. Let's start out with what is exactly ADHD? It used to be called ADD, but now we call it ADHD. So what is ADHD and how does it manifest itself in both adults and children?
That's right. Yeah. The H in ADHD was added at about somewhere in the early 1990s, and the reason was because we realized that kids with the disorder had as much hyperactivity as inattention. It wasn't just a disorder of problems with attention.
I see.
It's a disorder that has problems with attention, problems with hyperactivity, and problems with impulsivity.
Mm-hmm.
And it's very important for your viewers to understand that those are the three defining features of ADHD. Nothing else defines ADHD, not anxiety, not depression, not gender dysphoria. I know from talking to many ADHD adults and I do some Ask Me Anything sessions on Reddit where ADHD adults get to ask me questions, that many of them are confused. They think that because someone on TikTok said, I have ADHD and I'm gender dysphoria is caused by my ADHD. So they think they have gender dysphoria, therefore they have ADHD. Not right. If you have ADHD, it's only defined by having these symptoms, and the symptoms have to be evident for at least 6 months. They have to occur in multiple situations. We don't say ADHD just occurs in the home, but not at work. It's got to be multi-situational, and it has to cause problems. You might have ADHD symptoms, but if it doesn't cause any problems in living, it's not a disorder, and so it wouldn't be diagnosed with ADHD.
So tell me those three characteristics again, just so we lock those in.
Inattention, hyperactivity, and impulsivity.
Got it. Now, how does this manifest itself differently in adults compared to kids?
What happens over time, and this is a kind of gradually from childhood through adolescence into adulthood, is that the symptoms of hyperactivity and impulsivity tend to diminish. Symptoms of inattention and disorganization, those get stronger or stay the same. And so by adulthood, the adult with ADHD is typically very inattentive, but not too hyperactive, impulsive. You don't find them running around rooms and climbing on furniture like little kids do. Their hyperactivity can manifest itself in different ways. So they might be fidgety, for example, when they're sitting down. They typically don't like to have to sit for long periods of time, like they were in a conference room for 2 hours. They'd be the guy or the gal who gets up and starts pacing around. And that's how their hyperactivity might be manifest, but not in the frank hyperactivity of a young child.
And let's talk about the impacts on daily life. How can untreated ADHD affect work, relationships, and general well-being?
We do know that untreated ADHD has many adverse outcomes. I should emphasize that every person with ADHD has all of these adverse outcomes, but the disorder, when untreated, puts them at risk. We'll start with work life. At work, the adult with ADHD will have a harder time at work than their peers. And in fact, people with ADHD tend to shift jobs more often than others and have higher rates of underemployment or unemployment. In the home, they're more likely than others to have difficulties with their partners, also difficulties parenting their children. This is very clear from the evidence that I've reviewed on these topics. Other adverse outcomes in ADHD include a wide range of things, such as, for example, sexually transmitted diseases are more common among people with ADHD. Find that they're at greater risk for all kinds of accidents. Traffic accidents in adolescence and adulthood are the most common amongst people with ADHD, but the young child who runs into the street chasing a ball and doesn't pay attention to the traffic might get hit by a car and end up in the emergency room. And in fact, people with ADHD are more likely to have emergency room visits than people without ADHD. Mm-hmm. Sadly, people with ADHD are at higher risk than others for suicide. Mm-hmm. Now, the rates of suicide aren't very high, but they're higher than average, and they're higher than they should be. Mm-hmm. And there's evidence that treating people with ADHD stops these impairments. A good example comes from a wonderful study done in Sweden by my colleagues. This had to do with the risk that people have for ADHD for antisocial behavior or criminality. This is very real. What they showed was that during periods when people were treated, they were less likely to engage in criminal behavior than in periods when they were not treated ADHD. And we've seen similar effects of treatment on reducing the risk for traffic accidents and reducing the risk for many of the adverse outcomes associated with the disorder. So people have to understand that although ADHD is defined by the list of symptoms and the treatments reduce those symptoms, the main goal of treatment is to improve a person's life by reducing the life impairments that are caused by the symptoms.
Got it. And I want to emphasize that everything Dr. Faraone has just said is based on evidence and research. There's so much misinformation out there about ADHD. I just want to emphasize that everything you're going to hear in this show today is evidence-based. Do you want to confirm that, Doctor?
No, absolutely. In fact, I started the website adhdevidence.org for that very purpose, to provide information that was based on the science, based on published work. There's lots of BS out there about ADHD. You can find it in books that are on Amazon. You can find it on the internet. I only present evidence that has passed the criterion of being published in peer-reviewed scientific journals. And I will point your viewers to a special document called the International Consensus Statement on ADHD. It's a scientific publication that's also posted at my website. And it presents the top 208, basically the facts about ADHD that we, meaning a group of 87 people from all around the world, felt were reasonably substantiated to be endorsed in that document.
Wonderful. So that's ADHDevidence.org. I highly recommend you visiting it if you want to learn more about evidence-based ADHD. So, Dr. Faraone, tell us, why do so many people with ADHD go undiagnosed until adulthood?
There are several reasons. For girls with ADHD, their ADHD tends to be primarily inattentive. And if a boy is inattentive, they'll have the same problem. They won't get referred for treatment because they're not really bothering anybody. They are just being kind of spacey in the classroom and a little bit out of touch, but they're not doing things that are really annoying people. Mm-hmm. On the other hand, the hyperactive and impulsive person with ADHD, and boys are more likely to be hyperactive and impulsive, those kids really bother people. I mean, they get up in the schoolroom, and they walk around, they run around at home, they break things. And so those kids, because they cause someone else a problem, they get referred for treatment. And sometimes if the inattentive child not doing well in school, they will get referred for treatment, especially if a teacher realizes that they should be doing better. But it's very difficult, for example, if, let's say you have a very intelligent boy or girl with ADHD who's mostly inattentive, so they might be getting B's and C's in school when they really should be getting A's. Mm-hmm. And if no one realizes that, they'll never get referred for treatment. They'll just kind of go along in life. Now, what happens in adulthood is adults refer themselves for treatment because they're experiencing problems. And that intelligent person with ADHD who never got referred for treatment realizes, hey, I really should be doing better. Something's wrong here. They figure it out, they refer themselves for treatment, and they go on. We also have the other case of the child who has what you might call a helicopter parent. They're always hovering around, helping them out, helping them with homework, reminding them, helping them structure and organize their lives, which the person with ADHD finds very difficult to do. There's also teachers that can help in this regard. We call that scaffolding from the outside world. You're holding the kid up to protect them from their ADHD. Internal abilities, such as being very intelligent, being very creative, being very somewhat charismatic socially, those can also help scaffold you and protect you from your ADHD. Mm-hmm. But when you go into adulthood, most of that scaffolding goes away. The internal scaffolding is still there, but the parent scaffolding is gone. The teacher scaffolding is gone. Mm-hmm. And you have to kind of fend for yourself. And it's there where we see in transitions in life, we tend to see bumps in referrals for ADHD because those transitions can be very difficult.
So for college, for example.
Going to college or just starting a job as an 18 or 19-year-old, total change in your life. One way to conceive about ADHD is to think about it as a disorder of an inability to self-regulate important areas of life. Inability to self-regulate our motor activities, so we're running around too much or we're fidgeting too much. Inability to regulate our cognition, so we're disorganized, we're inattentive. Inability to regulate our impulses, so we get impulsive. Also relevant to that is inability to regulate our response to reward, and that's why people with ADHD get more involved in substance abuse. What happens is that the environment places demands on our brain for self-regulation, and our brains, when we're little kids, are not actually completely formed. The brain is not completely developed until about age 30, and the last part that develops is the part that's good at self-regulation. And so what happens is that when the ability of the brain to self-regulate is exceeded by the environmental demands on self-regulation, symptoms of ADHD emerge. If those environmental demands can be kept low, ADHD can be kept at bay for a while, and then it'll come out later on in life when something happens, like a woman has the first child, and that creates more demands on self-regulation. as you mentioned, you go to college, start a new job. So
ADHD often co-occurs with other mental health conditions. So you mentioned drug problems before, anxiety, mood disorders, and my understanding is that with uneducated doctors or doctors who need more training, those other conditions can be the focus of treatment rather than the underlying ADHD. Can you talk about the co-occurring conditions?
yeah, what you said is very important about the doctor's training, because ADHD, if we let's go rewind to about 1960. 1960, ADHD was just a childhood disorder. No one talked about ADHD in adults.
Mhm.
It wasn't until really around the early 80s that some people in the academic community started to realize, this is a disorder that affects adults.
Mhm.
And then late 80s, early 90s, in fact, when I was at the child psychiatry clinic at the Mass General, adults who thought they had ADHD would come to us for treatment because they couldn't get treatment anywhere else. And so we launched research programs into adult ADHD, which, and our work and other work, like the work of Russ Barkley, eventually ended up showing that ADHD in adults actually was a valid condition, that most kids with ADHD retained the disorder. So now we know it's a valid condition in adults, and we hadn't before.
Mm-hmm. And we know also now that adults are turning to their seniors and we know about ADHD, we have to differentiate other issues of aging with ADHD.
That's right. That's right. So you raised the issue about co-occurring psychiatric problems.
Yeah.
ADHD co-occurs with actually many other psychiatric conditions. We're finding now that there are, for example, genetic links between ADHD and autism, ADHD and anxiety disorders, mood disorders, and substance use disorders. And that corresponds to what we observe in the clinic. Somebody with ADHD is more likely to have these conditions. And so I think of ADHD as frequently an early warning sign because it's often the earliest disorder to onset. So if a doctor's doing a good job, they have a kid with ADHD or an adolescent with ADHD, they really ought to be monitoring them for the occurrence of these other conditions so they can be treated early. Now, when you and I were working on ADHDadults.com, one of the key problems that we were trying to solve was that doctors in primary care had almost no training in adult ADHD. Psychiatrists had some training. Doctors in primary care knew nothing about it, which is why we tried to educate them. What happens in primary care, and to some degree in psychiatry, patient comes in and the doctor, they're depressed, let's say, right? Or they're anxious. Two of the most common disorders. The doctor focuses on that. Never even asks the questions about ADHD, and they treat the anxiety and or the depression without inquiring about ADHD. What happens is that patient, the depression and anxiety might start to do better. They're typically not doing great, and it's because the ADHD is not being treated. So when we train any prescriber, any physician, any healthcare professional about ADHD, we always tell them you need to diagnose every disorder that's present. You need to ask questions that will get you into each of these disorders, because if you miss diagnosing a disorder that you can treat, you're really harming your patient, because you're going to give them 5 or 10 more years with struggling with this underlying disorder.
We'll be back to our show after this quick break. This interview is a fantastic overview of the latest evidence on what we know about ADHD from one of the foremost experts in the world, Stephen V. Faraone, PhD. Because there is so much valuable information in this interview, we are offering a PDF transcript of our conversation so that you can review, retain, and share the information in this interview. We are making this transcript available for only $1.99. Download your copy today so that you can refer to and share this valuable information about ADHD. As a bonus, you will also receive a copy of the World Federation of ADHD International Consensus Statement, featuring 208 evidence-based conclusions about ADHD and compiled by almost 80 experts worldwide. Download your transcript and bonus at bit.ly/ADHD evidence. So if a patient has multiple co-occurring conditions, which one do you treat first? Do you treat them all, or do you treat one? What's the order?
Well, the order is follows one common sense rule. That is, you decide which disorder is the most severe and is causing the worst problems. And if that's obvious, so for example, the patient's suicidal, you deal with the suicidality and depression first.
Mm-hmm.
If the patient has, is having a psychotic episode due to bipolar disorder, you deal with that first. Patients actively abusing substances, you deal with that first. After you deal with that more serious condition, then, as I like to say, kind of the dust settles and the smoke clears, you get a better view of the ADHD. And in some cases, the ADHD symptoms also go down, in which case maybe you don't treat it. Depends on the patient. But in many cases, the ADHD is still there and then it has to be treated. Of course, the reverse can happen as well. A person may be mildly depressed or mildly anxious, but their ADHD is really kind of very strong and causing serious troubles. Then you treat the ADHD first.
Mm-hmm.
Because of that kind of approach, many patients will end up on more than one treatment, and that's appropriate, like it is in any area of medicine, right? If you have two disorders, right? You have high blood pressure and high cholesterol, you get two medicines.
Yes.
And it's the same thing true in psychiatry.
Got it. Good. Now, I want to get on to treatments first, but before we do, I know there's a lot of reluctance for parents or even adults to go on ADHD medications. I know there's been a lot of research done on the effects of these medications, but I also wanted to talk about research I know you've done on other lifestyle changes or diet or exercise. And there's been research done on this. Can those changes make a meaningful difference for adults with ADHD? So lifestyle, diet, exercise, tell us about that.
Yeah, so the quick answer is no. That all of these kind of non-medical treatments that you mentioned in those domains have shown either no or minimal effects on symptoms of ADHD. The one possible exception would be a treatment with omega-3 fatty acids. And there's been evidence that there's a small effect on reducing ADHD symptoms. When I say small, I would say it's 20% of what you might get from methylphenidate or amphetamine, which people will know as Ritalin and Adderall. So it's a tiny effect, but it does seem real because many studies have been done on that topic. There are psychological therapies that have been tested. The only one that's really shown any evidence for efficacy is cognitive behavior therapy. But typically that's recommended to be done in conjunction with a medical treatment, in conjunction with a medication. It doesn't work so well on its own. There's nothing wrong with trying it by itself at first. In milder cases of ADHD, that might work. But I wouldn't do that for too long if it's not actually helping solve the problem.
Got it. So let's talk next about diagnosis and assessment. How does, if you think you might have ADHD, I know the story that a lot of adults figure out that they've got ADHD when their kid gets diagnosed.
Yes.
They say, oh, yes. This sounds just like me when I was a kid.
Yeah.
So how does diagnosis and assessment take place? Tell us a little bit about that.
Well, firstly, the only way to diagnose a person with ADHD is to sit down with them and talk to them about the 18 symptoms that define the disorder.
18.
The clinician just has a conversation and asks them about what's bothering them in their life. You want to understand what brings them into treatment, what the problems are, but you also want to start moving the conversation towards these specific symptoms that correspond to inattention, hyperactivity, impulsivity. You'll ask them about, are they, going to give you examples of when they've been easily distracted. And typically the patient with ADHD will tell you these things without you having to prompt them, which is the best way to get the information. But sometimes you have to prompt them so they or their significant other can help you understand the nature of their disorder. Once you ask all these questions and you make sure that the disorder occurs in multiple situations and that you make sure that it's impairing them in some ways, then you can move towards making a diagnosis. Importantly, and this is something many of my colleagues don't understand. I'm a psychologist, and many psychologists still think that you can give psychological testing to determine if a person has ADHD or not. Or they think that psychological testing can rule out ADHD or rule in ADHD or be useful in diagnosing ADHD. And the answer to that is totally, totally wrong. It should never be a part of the diagnostic process for the disorder. Now, having said that, I will also say that psychological testing is useful for lots of other purposes. For example, planning an educational program for a child, helping an adult figure out what types of work they should pursue, helping anybody figure out what their strengths and weaknesses are from a cognitive point of view. But these tests are not to be used as a method of determining is someone ADHD or not ADHD. And if anyone's been told by their psychologist that they don't have ADHD because of their psychological testing, they need to see another doctor because that's just not appropriate.
Okay. We don't have time to go through all 18 symptoms, but can you give us like an overview of what a doctor would be looking for to diagnose ADHD?
We'll ask, for example, regarding hyperactivity, they want to ask questions to find out if it's a child, if they seem to run around more than the average child and climb on furniture and do things of that sort. If it's an adult, they'll ask about fidgeting and feeling discomfort in certain situations.
Mm-hmm.
When they ask about impulsivity, one way to ask about that is to talk about acting without thinking. You ever get the impression that your child acts without thinking, does things so spontaneously that they get into trouble? And the same kind of question is useful for an adult. You barge into conversations. Are people annoyed? Does that annoy people because you cut them off during conversations? In attention, you ask questions that kind of focus on the ideas of one that would be sustained attention. Do you have trouble kind of focusing on a project for long periods of time? You ask to think about distractibility. Does your mind easily wander from one task to another so that you can't get things done? Those are the kinds of issues that you're going to talk about, and you'll ask some very specific questions to get at those 18 criteria, because the person has to have at least 6 to be diagnosed with ADHD as a child, but as an adult, you only need 5 because we know the symptoms diminish over time, so the threshold is a bit lower for adults.
Got it. And when does ADHD make itself apparent? Can this happen at any age, or is it in childhood?
So if we talk about ADHD is still by definition a child onset disorder. It has to be diagnosed. It has to occur before age 12. Mm-hmm. Now, it doesn't mean that some people aren't diagnosed later. Many are. And it's one of the more difficult problems for a clinician when they're faced with a 40-year-old who seems to have ADHD but doesn't remember their childhood very well. That can be difficult to make the diagnosis. And we don't have time to go into that, but there's ways we train doctors to deal with situations like that. Mm-hmm. It rarely onsets in adulthood. It can for some reasons. For example, somebody has a minor traumatic brain injury. It can also lead to ADHD that will be responsive to the treatments for ADHD. Mm-hmm. Women going through menopause, hormonal changes at perimenopause and menopause can increase a person's ADHD. One thing I haven't said yet, and I should go back to the nature of ADHD, is we've been talking about it as a disorder, which it is in the medical literature, because we have to define the person as yes or no to treat them. But we actually know from a lot of good data, both from epidemiological studies of both kids and adults, show us that the symptoms of ADHD are actually normally distributed in population. That's a kind of a mouthful. What that means is that there's this gradient of people who have no symptoms, people who have a little symptoms, people who have medium symptoms, to people with a lot of symptoms. But there's no clear cut point that separates out people with lots of symptoms and other people. So ADHD is more like a trait in the population. Everybody has a little bit. And it's only it's sort of like, ADHD is more like hypertension. Everybody has a blood pressure, but if your blood pressure is too high, you need to get it treated. And that's really important in understanding the disorder.
Okay, good. So let's talk about treatment options. What are the treatment options? How do they work?
Okay, so we'll start with the medical treatments, the medicines. The most well-known of these, because of the media and the internet, would be methylphenidate. People know it as Ritalin, or amphetamine. People know it mostly as Adderall. There are other versions. For example, Concerta is also a methylphenidate. Vyvanse is also an amphetamine. There are many, and this period that we're living in right now, there are many companies selling different, what we call formulations of those 2 basic compounds. And what's important for, I think, your viewers to know is that one of the main differences is what we call duration of action. So some of these medicines will only last for about 4 to 6 hours, so you have to take it multiple times in a day. Others will last for 8 hours or 12 hours, or even one of them lasts as long as 15 hours. And so when someone's being prescribed one of these medications, one of the goals of the prescriber is to figure out what's the best duration of action for this person, for the kind of lifestyle that they live. Mm-hmm. And those medicines, methylphenidate and amphetamine, are called stimulant medications, and they've been around the longest. They those are the two medications which unfortunately have gotten a bad reputation because of misinformation in the media. That also stimulants also happen to be drugs of abuse. So we all know that people, for example, abuse amphetamines. And when I say, and that's a problem that we have to deal with in the real world. But what we do know is that when these medications are taken as prescribed, they don't cause people to become substance abusers. It's just the opposite. They actually help protect people with ADHD from becoming substance abusers when used as prescribed. They do have the problem of what we call diversion actually, the diversion occurs at all ages. Some parents will take their kids' medications and they'll use it themselves because they want to stay up late at night. Diversion is the biggest problem among older adolescents and college students. College students they'll find someone with ADHD, they'll buy their medication, and they might use it to stay up late at night partying or stay up late studying. Mm-hmm. This is real. It's not yet an epidemic, but it's something that many of us are working on to try to reduce its impact. So those are the stimulants, and they tend to be the first medication used because they're the most effective. So on a scale of 0 to 10, stimulants are about 8 or a 9.
Okay.
Now, there's another class of medications called non-stimulants. The first one was atomoxetine, which trade name Strattera, and they work in a different system. The stimulants mostly work in the dopamine system, a little bit in what's called the noradrenergic system. Atomoxetine works mostly in the noradrenergic system of the brain. It's very effective for some people, but on average, it's less effective than stimulants. So instead of being an 8 or a 9, it might be somewhere between a 5 and a 7, depending upon childhood versus adult treatment. Mm-hmm. And then there are two other drugs that affect the noradrenergic system, use a different mechanism than atomoxetine. One of them is, two of them are what are called alpha-2 agonists, guanfacine and clonidine. Both are long-acting versions. And we also have a new drug called extended-release viloxazine, it came out a year or two ago. And this is very much like atomoxetine in that it's a norepinephrine reuptake inhibitor. It affects the same protein in the brain, but it also seems to have some effects in the serotonin system. And some of the data suggest that it has less adverse effects and is easier for doctors to dose than atomoxetine. And so that's relatively new, and we're currently getting a view on how it actually works out in real world practice.
So you mentioned that the effectiveness on the stimulants are on a scale of 1 to 10, about an 8 or a 9, and then the non-stimulants are about a 5 or a 6.
They're more like 5, 6. They might go up to 7 in some cases, but they're lower. Yes.
Got it. And just for comparison, what we talked about before, which is diet, lifestyle, exercise, what affects
most lifestyle changes have a 0 effect. The only one that apparently has some effect is omega-3 fatty acids, and that's around 2.
Okay, good.
That's around 2 out of 10.
Good. So that's a great comparison for parents or even adults considering what to do about ADHD, is these natural remedies really have a very, very low effect compared with medication.
I have to tell you that it's, I know parents think they're doing the right thing, but I will say to them that if you have a 5-year-old that you've been told has ADHD and you spend 5 years looking for an alternative treatment that works, that means by the time they're 10, they've spent half their life being crippled with symptoms of ADHD. Mm. And that means they're falling behind in school, they're falling behind in social relationships, and you really harmed them. Because as a parent, many of us tend to over-focus on what we read about the side effects of medications, and we don't realize that there are also side effects of no treatment. Mm. Not treating oneself also leads to harm. And in the case of ADHD, it's a lot worse not to treat a child compared to the potential adverse risks of taking the medications.
We'll be back to our show after this quick break. This interview is a fantastic overview of the latest evidence on what we know about ADHD from one of the foremost experts in the world, Stephen V. Faraone, PhD. Because there is so much valuable information in this interview, we are offering a PDF transcript of our conversation so that you can review, retain, and share the information in this interview. We are making this transcript available for only $1.99. Download your copy today so that you can refer to and share this valuable information about ADHD. As a bonus, You will also receive a copy of the World Federation of ADHD International Consensus Statement, featuring 208 evidence-based conclusions about ADHD and compiled by almost 80 experts worldwide. Download your transcript and bonus at bit.ly/ADHD evidence. So with all these options, how does a doctor figure out which is best?
Well,
What's
one
that
way
process?
so doctors will follow existing guidelines that have been published by American Academy of Child Psychiatry, by the American Academy of Pediatrics, for example. And they typically will say, start with the stimulant first, and then if that doesn't work, try the other type of stimulant. That doesn't work, go to a non-stimulant. That's usually the case. There are some exceptions to that sequence, for sure. Some people do it differently. So, for example, in our adult ADHD clinic at SUNY Upstate, we use a non-stimulant medication first, partly because we're worried about all the diversion risks of the stimulants. And we also know that when we talk about non-stimulants, being say a 5 or 6, and stimulants being an 8 or a 9, that's on average. But we also know that some people do as well on the non-stimulant as they would on a stimulant. It doesn't mean that you're denying somebody a good outcome. You're just finding those people who will have a good outcome early, and then if they don't have a good outcome, you move them to the other drug. I just have to also remind people or tell people that, unfortunately, there's no way to predict what's the best medicine for your child or for yourself. It's a process of trial and error. The clinician's experience helps somewhat, but it's basically comes down to trial and error, for sure.
Because everybody's going to be different in terms of how they react to the medication.
Everybody's different, and many of us, myself included, have been and are looking for predictors of treatment response so we can personalize medicine, and we're not there yet.
Okay, so if you're just beginning to get treated or have your child treated for ADHD, you should expect this is an art, not a science, and you may have to try a number of different solutions to find the best result.
That's right. And there are companies that sell kits, what we call pharmacogenetic kits, where you can do genetic tests, and they'll make suggestions based on your child's genetics or your genetics, what is the best treatment. I don't recommend those kits to be used because they're not really based on strong enough data to be useful in the clinic.
Got it. Okay. Now, I want to talk a little bit about all the misinformation that's out there, but because it really has created medication suspicion and lack of compliance. Tell us, what is the science around these medications? Are they safe? Are they effective? And also, if you don't mind, tell us some of the side effects that people can expect that yes, it's a side effect. All medications have side effects. So tell us those.
Okay, so number one, obviously, all of these medications we're talking about have been approved by the U.S. Food and Drug Administration as being safe and effective. And that's a very high hurdle. I've been part of those discussions. And the FDA is a very tough organization. Some of these medications have been used for decades. Let's talk about the stimulants, because most of the concern about adverse effects is with the stimulants. They've been used in kids. They've been approved for use in kids since the 1960s. And they've been used on millions and millions and millions of children without substantial adverse effects. Adult treatment is relatively new, but we've seen the same history. These medicines are even used in the elderly. Adults with dementia will be given a little bit of Adderall or a little bit of Ritalin because it helps them be a little bit more sharp. It also helps them stay awake. In fact, my dad had Alzheimer's disease, and at the age of like 85, 90, he was taking Ritalin. And the Ritalin didn't hurt him. And elderly, of course, are if you talk about the most vulnerable population in terms of where medication side effects occur, elderly are the most vulnerable. So there's a lot of data to suggest, including the clinical trials, because the clinical trials track adverse effects, and the ones that occur are listed. The FDA lists those effects, and the effects listed don't occur in everybody, but they do occur in some people. The most worst effects would be cardiovascular effects, but if the doctor has done the work appropriately, the child is screened for any pre-existing cardiac problems, and those effects therefore won't occur. In fact, the FDA has looked at this multiple times and concluded that the stimulant medication do not have adverse cardiac effects.
Okay, good.
those medications have some effects on reducing the rate of growth. Now, in the US, losing weight is not a problem because most kids are obese these days. So that's not really an issue. There is some evidence that some kids will have delays in their growth in height, which can be a problem. But what we found is that those delays in height are usually fairly small. They're only, they're on average about 1 centimeter a year for the first year or 2 or 3, and then they tend to attenuate. And they also reverse if the treatment is taken away and there's another treatment. And we had no evidence that any children were getting unusually small. In other words, meeting criteria for being dangerously small. So growth is typically not an issue anymore for either pediatricians or child psychiatrists treating, because they track growth. And if they see it's a problem, they just change the medication and so forth. Other adverse events are minor. There can be sleep problems. There can be loss of appetite, for example, with the stimulants. Those are 2 major ones. Although I will mention with sleep problems that ADHD itself causes sleep problems. And so when the parent is starting, especially with a child or even adult starting medication, they have to keep in mind what was the baseline level of sleep problems before the medication, and has that really changed over time?
So these side effects, I want you to give us some comparison. The side effects of the medication versus the effect of the medication. The question is, should I not take the medication because of the side effects, or should I take the medication because of the benefits of the medication?
Well, not taking the medication means that you're placing your child or yourself at risk for many adverse outcomes: substance abuse, accidents, difficulty in relationships, difficulty in school, getting lower grades than expected, later in life, not doing as well financially as you might do, not being able to attend college or dropping out of college. We talked before about sexually transmitted diseases. These kids with ADHD get into early sexual relationships with unprotected sex. They're more likely to have kids at an early age, earlier than they would have planned, because they're not very planful as part of their ADHD. You can mention criminality or other antisocial behaviors that literally can get them in trouble with the police. When I was a young man, I would take my kids to the bus stop. There was a kid at the bus stop who I knew had ADHD. I could just see it. I just mentioned to his dad, "Look, I don't want to get into your business, but I think your child has ADHD. You should talk to your doctor about it to be sure." And what he told me was that, "Oh, yeah," he says, "we looked into it, but we just don't want to have to give him some medicine for this. He's just a kid." And I saw that kid evolve over time. Wonderful guy, but he got involved in drugs, got involved in antisocial behavior, ended up in jail. And I can't guarantee that would have been stopped by treatment, but there's a good chance that it would have been stopped if he had gotten treatment.
Got it. Okay, good. Let's talk a little bit about executive function, what that is, and what are the ramifications of that if you do have ADHD, and does the medication help with executive function?
Yeah. So the executive functions are those functions of the brain that control our ability to organize all of the information that we're being bombarded with every day. And the seat of the executive functions is in the frontal lobe of the brain, the part that's right about here. It's the part that develops later in life. The executive functions tell us when it's appropriate to start doing something, when it's appropriate to stop doing something. They help us in this process there's a process in the brain that occurs where well, let me back up a second and to simplify it, to say you can think of 2 main networks in the brain. One is an executive control network, which is organizing and getting tasks done. And then there's what's called the default mode network. That's the brain at rest. That's when you're just kind of lying on the beach looking at the sun and not thinking about anything in particular. Your mind's kind of wandering from here to there, whatever, but there's no focus on any one thing. The process of switching from default mode to executive functions is very important, because if you're on the beach, let's say, and in your default mode network, and say you're a parent of a child, your child starts screaming for help. Now, the average person jumps up because the executive control network goes into action, takes control, and does what needs to get done. you're a person with ADHD, you might not be able to switch into executive control fast enough, and that could cause a problem for the child. So you can think of the default mode network as kind of an internal distraction that distracts adults from the executive network, which is executive function, things very task-oriented, organizing, remembering, putting things in correct sequences, getting tasks done. That's where ADHD people have a lot of trouble at all stages of life.
Got it.
And yes, the medications do help with those executive functions.
Okay, good. That's what yeah. So there's those two issues there. There's the 18 symptoms that we discussed before, but then there's also executive function and the two parts of the brain that got to work together when necessary. And so the medication can also have a beneficial effect on executive function.
I want to also tell your viewers that another aspect of executive functioning is also what we call emotional regulation. Also organizing our emotions, regulating them, understanding them, and dealing with them. So the average person experiences let's talk about road rage, right? You're driving along the highway to work, Jonathan, and somebody cuts you off and you get angry and anger flares up. But you have the ability to calm yourself down and self-soothe so you can focus on the road, you can continue driving. A person who can't regulate that emotion, that intense emotion takes over, and they can't soothe themselves, they can't calm themselves down. And because they're angry and upset, they might get into a traffic accident. They may chase that person and get into a road rage type of incident. So also organizing and dealing and coping with emotions is part of executive functions.
Great, good. So before we leave, I wanted to talk about research and future directions. What are some of the most exciting areas of research in ADHD right now?
Okay, well, number one, I would say genetics, partly because my heart is there. I did a lot of work in genetics in my career, and we now have a much better understanding of the molecular genetic basis of all psychiatric disorders. And I think over the next decades, that work is going to lead to better methods of diagnosis and treatment. But it's going to take a while because it's a very complex problem. It's not a simple problem, complex. In fact, we know now that there are probably 7,000 parts of the genome, we'll call them genes, 7,000 genes that are involved in causing symptoms of ADHD. So it's a very complicated problem.
Yes.
There's a lot of work being done in the area of, let's call it neuromechanistic kinds of treatments. So treatments that use some sort of method to try to change the brain directly. One that's been approved by the FDA is called trigeminal nerve stimulation. And that's actually been shown by a colleague of mine, Jim McGuff at UCLA, to be safe and effective for treating ADHD.
Can you repeat that name? Can you repeat that name?
It's called trigeminal nerve stimulation, or TNS.
TNS, okay.
And there are other types of methods people look at to stimulate the brain with magnets and other approaches to make an adjustment, if you will, that will reduce symptoms. Some of them seem hopeful. None of them none of the other ones have been approved yet by the FDA or the European agencies, so they're not currently available. But a lot of progress is being made there. I'm very impressed with that. A lot of work being done with anything you can put on a smartphone that might help a person with ADHD, apps, if you will. And there's loads of them out there. Nothing really has risen to the fore as something which is dramatically useful, but people are working on it, and I think they'll get somewhere. There was a whole area of research, an entire area of research called cognitive training, where you try to retrain the brain, for example, to do better at remembering things. And the early studies showed that you could train the brain to be better at remembering things, but it didn't really help their ADHD. Now there's some studies that have come out. Mike Koffler at Florida State University in Tallahassee has got a method which seems to have some effect on ADHD symptoms, and I know he's working more on that because it's still not ready for prime time, but we are seeing some hope in those areas. One area that needs a lot of work has to do with helping people adhere to their medications. It's the biggest problem we have. People stop taking their medications. So there's a lot of excitement in the air. There's a lot of good things coming at new medications that are being tested. That will be one for sure. I should say for sure. One, my guess is will eventually in the next year or two will be available. Another new non-stimulant, centanafidine, but we have to wait and see if the FDA actually approves it. So lots of good things out there, Jonathan.
Good. So you mentioned genetics before. I just want to go back to a basic of ADHD. It is genetic. right? I mean, it's passed through in families, correct?
Yeah, absolutely. We can tell from twin studies, and there are many, and they're like 37 or something now, that the heritability of the disorder is approximately, it's close to 80, let's say 80%, 75, 80%. That means that we can account for 80% of ADHD in the population by genetic predisposition. We don't really know a lot about environmental risks, unfortunately. There's a lot have been studied. There's a lot of environmental, we call them associations that, they seem to go together. But with environmental work, you can't do a controlled study. And so it's really hard to rule out that an environmental risk is a real risk. So for example, for a long time, I thought from the data that if mothers smoked during pregnancy, that would cause ADHD in their unborn child. Because that's what the data seemed, there was an association there. But it turns out that association occurs because mothers who smoke are more likely to have ADHD. So they're actually just passing the genetics along. So we were fooled by the data because the early studies didn't actually look at mother ADHD.
Mm-hmm.
There are some environmental causes we're pretty sure of. For example, say very sure of traumatic brain injury is one example. We do know from some really excellent studies done by my colleagues in the UK that very adverse environments very early in life, where there's nutritional and emotional deprivation, can lead to an ADHD syndrome.
Mm-hmm.
They studied kids that were raised in Romanian orphanages under that Ceausescu regime. And these kids were just left in cribs, barely fed, never picked up. And they had all sorts of problems, including ADHD when they got older.
Mm-hmm. Interesting. So, Steve, I want to thank you so much for being with us today and kind of updating us all on ADHD. We've been talking with Professor Stephen Faraone, PhD. He's a distinguished professor of psychiatry and behavioral sciences at SUNY Upstate Medical University. He's the principal at the Institute for Human Performance. He's the president of the World Federation of ADHD, and he's also the principal at the ADHD Evidence Project. You can visit there. I highly recommend it. It's ADHDevidence.org. And I just want to say on a personal note, Steve, and for the rest of my audience, that Steve and I worked together for 10 years on ADHD in adults. And it's really with Steve that I learned about evidence-based medications, evidence-based studies, clinical trials. And this has really been the motivation for me to start Go to Health. So Steve, I want to take my hat off to you with all that I learned in working with you over 10 years, and that this is the result that we have today is Go to Health, which is promoting evidence-based medicine.
Well, Jonathan, thanks to you, first of all, for having me on. I appreciate that. And it's also great to see you continuing in an evidence-based way. There are so many people peddling snake oil out there, but to spend the extra time it takes to figure out is this real or not, in the end, that's really what's going to help viewers, for sure.
Good. Again, thanks so much for being with us today, Steve.
Happy to be here.
And you can go to ADHDevidence.org to learn more. This has been Jonathan Marks with Go to Health Media. And as we say at the end of every show, Go to Health. Take care. We'll see you again next time. Bye-bye. This interview is a fantastic overview of the latest evidence on what we know about ADHD from one of the foremost experts in the world, Stephen V. Faraone, PhD. Because there is so much valuable information in this interview, we are offering a PDF transcript of our conversation so that you can review, retain, and share the information in this interview. We are making this transcript available for only $1.99. Download your copy today so that you can refer to and share this valuable information about ADHD. As a bonus, you will also receive a copy of the World Federation of ADHD International Consensus Statement, featuring 208 evidence-based conclusions about ADHD and compiled by almost 80 experts worldwide. Download your transcript and bonus at bit.ly/ADHD evidence.
Thank you for tuning in this week to Go to Health Media. Be sure to join Jonathan Marks and another health expert next time. You can also catch the program on your favorite podcast platform. Until our next show, be sure to visit us on the web at gotohealthmedia.com and elevate your life.